Good evening, everyone. Thank you so much for being here. I'm Kelly Cannon. I'm the Scholarly Communication Librarian here at Muhlenberg. Welcome, everyone, to this event. We would ask you, just a reminder, during the Q&A, if you could please step up to the mic. We're live streaming this event, so everyone who talks needs to talk into a microphone. Welcome, everyone, to the 5th library-sponsored public health panel at Muhlenberg on pressing health concerns. In the past, we've done such topics as the Zika virus and the opioid crisis. As a teenager, I read a beautifully written but very dark novel called The Plague by Albert Camus. It tells of a city in Algeria in the 20th century that experienced a bout of the bubonic plague and is temporarily quarantined from the rest of the world. At the time I read the novel, I could not relate to this fictional plague, but I very much admired the doctor, Bernard Rieux, who in the face of an overwhelming foe quietly cares for the sick and dying. One quote from the novel resonates with me today, speaking of the community under quarantine. Quote, "No longer were there individual destinies, only a collective destiny made of plague and emotions shared by all." Although we are not under quarantine at the moment, the pestilence known as COVID-19 has brought us all together this evening with shared questions. How does the disease spread? What are the chances of our being infected? What is the larger impact of the disease? To help us answer these questions, we're very honored to have with us tonight 5 experts helping us to see COVID-19 not from just one discipline, but from several. Please know that these aren't by any means all perspectives on the disease, but just a snapshot. First tonight, we'll hear Chris Cronin from the perspective of public health. Second, we'll hear Rachel Hamillers from information science. Then Casey Miller from anthropology. Then Kathleen Baczynski from public health. And finally, Lufei Tang from economics. Chris?
Thank you, and thank you everybody for coming. It's nice to see you out and about in public at a time like this. We did expand to a bigger room just so we wouldn't have so much close contact. Before I start my presentation, I just want to give a shout out to some people. And those people are the people who are working tirelessly at the CDC and the World Health Organization and the Pennsylvania State Department of Health and the Allentown Health Bureau, and right here at Muhlenberg College. We have been working on this for weeks to make sure that we are prepared, and I'm happy to say that we are. We're as prepared as we can be, and it takes a country to prepare for something like this, and that's what you're seeing now. So I'm up here to talk a little bit about the epidemiology of COVID-19, some of the science behind what we're hearing about. I'll talk about how the disease is transmitted, what the symptoms are, and also prevention measures. There's a lot of information out there. I don't have any numbers per se to give you because the numbers are changing all the time, and quite frankly, they're unreliable, and I will touch on that unreliability a little bit, and then Rachel will follow up with that. So this is a beautiful picture put out by the CDC of the coronavirus, and as a microbiologist, I appreciate this so much. It's absolutely spectacular. So what do we know? This is what we know, and this is what I'm going to talk to you about today. We know that the new virus belongs to a family of viruses called the coronavirus family. It is an enveloped virus, and it contains a nucleic acid called RNA. And that's important because that sort of identifies this virus as a little bit special and belonging to this family. It's interesting that it's enveloped, and that envelope contains a lipid substance or a fatty substance. And so soap is very effective in destroying it. So that's why you're hearing people say use soap and water. That's the preference if you have it available, because the soap will disrupt that envelope layer. There are 7 known human strains of the coronavirus. 4 of them cause the common cold, and I'm sure we've all been infected by some of those more common strains, but 3 actually are much more serious and cause more severe respiratory illness. And you've heard of SARS, you've heard of MERS, and now the 3rd one is COVID-19. So where did it come from? Well, that's a good question. I can tell you where some of the other ones came from and what we speculate is happening here. So coronaviruses are called zoonotic viruses, which means they originate in some animal somewhere. Typically, they are carried in an animal, transferred to some kind of intermediate host animal, and then eventually make their way into humans. And we saw that in 2002 when the SARS coronavirus came into being. It's thought that that came from bats originally, then infected civet cats, which then infected humans. With MERS in 2012, again, it's thought that this virus originated in bats and then infected camels and then infected humans. And for COVID-19, we have no idea yet. We don't know for sure where it came from. The likely genomic sequence leads us to believe that it came from a bat or originated in a bat. We don't know yet what the intermediate host is at this time. So China first reported its cases of a severe respiratory illness at the end of last year in December 2019. And this was a outbreak in Wuhan in Hubei province. And because of our ability now to do rapid genome sequencing, we were able to identify the causative agent quite rapidly. Those of you who were around during the HIV era probably remember that it took us almost 5 years to figure out that that virus is what was causing the syndrome called AIDS. Now, in less than 12 weeks, we have sequenced the genome, we have identified the virus, we have developed a test for it, and we have vaccines in clinical trials already in 12 weeks. So we are moving faster than we've ever been able to do so in the past. So we know how it's transmitted. We know that it is transmitted directly through respiratory droplets from person to person. So if somebody coughs or sneezes or speaks and some of their infected droplets land on your mouth or on your nose or in your eye, then there's a high likelihood that you will actually be infected. We also know that you can have indirect infection or indirect transmission, and that means that you come in contact with one of those infected respiratory droplets on some inanimate object like a doorknob or a table or a chair or a water fountain handle. And so we also know that given the size of the virus and the usual size of respiratory droplets, that anywhere from 3 to 6 feet is a distance where those droplets can travel. So that's why you're hearing people say social distance yourself, meaning get 3 to 6 feet away from anybody who's coughing or sneezing or potentially infectious. We should be doing that anyway. Oh, and one other thing, it can be spread from an asymptomatic person who is infected. So someone who is infected but is not showing symptoms or is showing mild symptoms can spread the disease. And actually, in the last 24 hours, information has come out, credible information that shows that this disease can actually be spread easier in the early stages of the disease than later in the disease. SARS was one of those diseases that spread better the later on you were in the disease. So what's the illness look like? There's an incubation period, which means the time between when you were exposed and when you start to show symptoms of 2 to 14 days, anywhere in there. The average is 5 days. Most healthcare providers are reporting that people are showing symptoms within 3 to 5 days, mild. If the disease is going to get severe, they're usually seeing that between day 7 and day 10. The symptoms can range anywhere from mild, where you feel like you might have a cold, to moderate, where you have fever, fatigue, maybe a dry cough, some shortness of breath, and then severe, which is the severe pneumonia and acute respiratory distress. So people are wondering what their risk is. Right now, based on what we know, the data that we have coming out of China and Iran and Italy and South Korea, what we know is 80 to 85% of the illnesses will actually be mild or asymptomatic. We know that children ages 0 to 19 have minimal risk of severe illness and death. So that's good news for our college-age population here. You might not even know that you are infected. 15 to 20% of the cases will have moderate or severe symptoms. These include adults over the age of 60 and also any individuals who are immunocompromised, so people whose immune systems aren't working as strongly as they should be have an increased risk of severe illness and death. So you probably have heard a lot about this number, this case fatality rate, like how many people are dying or what percentage of the people are dying. And you notice that I don't have a number up there because we don't know for sure. And so all of these numbers that are being thrown out, like 3.9, 2.4, President Trump has a hunch that it's less than 1%. We don't go on hunches in science, we look at the data. And so the numerator here to calculate a case fatality rate is the total number of people who die from a disease. The denominator is the total number of people who have the disease. And the only way to know how many people have a disease is to either, is to definitely test them, but also to be sure that everybody who is sick or might be sick is tested as well. And that's a very hard number to come by. So the bottom line is we don't know yet what the case fatality rate is. We don't know if this is a highly virulent disease or a mild disease. We just don't know. We hear about a lot of people who are dying, but what about those people who might not even be going to the hospital or the doctor to begin with? We haven't accounted for them. So here's a picture. This is as of February 11th, and this is a snapshot of China, and only China, not a global picture. But I thought this was a very good picture because what you're seeing is a comparison of seasonal flu to COVID-19. And I have heard people say, oh, it's just the flu, it's no big deal. Well, maybe that's the case for 80 to 85% of the people, but people do die of the flu. A lot of people, about 20,000 people in the US so far this year. And this COVID-19 infection seems to be a little bit more robust than influenza. So you can see there on the right that all ages in China, as of February 11th, there was a 2.3% case fatality rate, and for all ages, 6%. Look at the bars on the right of the graph, the blue one and the orange one. Those are the older age groups, and those are our most vulnerable people right now. We don't know why. Maybe it's because they have other illnesses that make their immune systems weaker. We just don't know. So there is a test to diagnose it. Based simply on symptoms is very difficult because these symptoms mimic so many other illnesses. But there is a test. It uses PCR. Testing is becoming more widely available in the United States, but it is still scarce. At the beginning, the CDC was the only agency that was testing, and now we have capabilities in all 50 states at the state health departments. Private labs like Quest and LabCorp are now also testing, and academic institutions either are or will be testing soon that have those testing capabilities. Muhlenberg would not be one of them, but I heard that Stanford is testing and Harvard is testing. 2 tests are required per patient to confirm results. So if you hear that there are X number of tests available in the United States, divide that by 2 because there are 2 tests per patient. The test kits contain many tests. So if you hear on the news that, the Pennsylvania Department of Health, for example, got 25 test kits, well, each one of those kits has a capability of testing upwards of 700 tests. So kits and tests are being used interchangeably, and they really shouldn't be. The test consists of a nasal or throat swab. There's currently no vaccine or treatment. There's no cure, so if you do go to the hospital and you need to be cared for, treatment is supportive, which means that they will give you oxygen and they might put you on a ventilator and just treat your symptoms, but there's nothing they can do to make you get better faster. Right now, there are no antiviral drugs that are approved for this disease, and like I said before, a vaccine is not likely for a very long time. And even if we do get a vaccine out and rolling in the next few months, there are 7 billion people on this planet, and we are not going to get those vaccines out for everybody at the same time. And that's something that, you need to think about. Who's going to get those vaccines first? Like, what's the hierarchy there? I've already put in for mine, so. So, prevention. Look, it's up to all of us at this point. We can't just depend on the government. We can't depend on Muhlenberg College. We can't depend on our doctors to have some magic wand that says you're going to be fine. We have to take individual responsibility in public health, and that means we have to make sure that we prevent ourselves from getting it and that we protect others from getting it, so we don't want to spread it to other people. It's our job to do that. And so you've heard, cover your coughs and sneezes, wash your hands often with soap and water, and if you don't have soap and water, use hand sanitizer. Clean and disinfect, including your cell phones. And Apple just came out today and said, yeah, it's okay to use disinfectant wipes on your cell phones. So they just don't want you to submerge it into like a bucket of Clorox. But they used to tell you, don't do that because it would disintegrate the outside casing. And today they said, no, you should be okay. At least once a day, disinfect your phones. Your phones are filthy. And please stay at home or out of class if you are sick. And my students know. You come to my class sick, I'm like, go away until you're better. But we all need to practice that. Don't come to work. Don't go to work. Don't come to class if you are sick with anything. And, we'll cut down on the spread of a number of illnesses. So that's what I have. I'll take questions later. Right now, Rachel Hamlers is going to come up and talk to you about how to find credible information. Get rid of this. Okay.
So I'm going to time myself. I'm Rachel Hamlers. I really wish this mouse pad would work. I am the teaching and learning librarian here at Trexler Library. I study information, the flow and amount of information in this virus. Media Tech, one of you is going to have to come help me because the mouse has disappeared. And so I have been overwhelmed by this because there is so much. You can see it up there, but you can't see it on the screen. So I'm just going to start talking because my slides are, my picture of the virus is not as pretty as Chris's, so we can just, and eventually someone will come put up my slides.
Keep going.
So I was listening to The Daily, which is an awesome podcast from the New York Times on February 27th, which was only 2 weeks ago, but obviously in COVID-19 time is like years and years ago. But just like in this presentation, right, they started out with a list of things we know and don't know. The first thing that we know, it's a virus, which I, like Chris, right, I study HIV and AIDS. And so HIV and AIDS, we didn't know it was a virus until 4 years in. We didn't prove that it was the virus that causes HIV for, another many months after that. So even knowing it's a virus to me is a huge deal. Oh no, we're still in Chris's presentation and not mine. And I still have no mouse. Helpful people. So we also, right, the virus has already been genetically sequenced, which, again, pretty incredible. And we have a lot of other information. We have this study out of China that says 80% of cases were severe, that there was a 2.3% death rate. And all of these things might sound pretty normal, right? Not this is a normal disease, but this is a thing we normally know about diseases. Oh, that one. Oh, duplicate these displays. You're so smart. Thank you. I want that one. This is like being at a restaurant. I can't talk until we get seated at the table. All right, so now I can talk. So these are things we normally know about diseases, but actually, to me, as a studier of science communication, this is a pretty extraordinary thing to know all of these things when we have known that this virus is in the human population for all of about 3 or 4 months. So it's pretty incredible to me that we have all of this information. So I'm interested in seeing how are we getting the science information and what information are we getting that appears to be scientific, but really, right, is not representative of what the science PD knows. So I'm going to start with that, because why not start with the bad news and then go to the good news? So if you've done a Google search on COVID-19 lately, anyone? Yeah, great. I bet it's trending. You will maybe get search results like this that I got on Sunday, and you can see 2 of my 3 top hits mention numbers, right? US COVID-19 cases top 400, including first in DC, Department of Health, second case of COVID-19 identified in Indiana. So again, I have a hard time not comparing this, although a very dissimilar virus, to the AIDS epidemic. But then as now, I would say that the media was giving us daily or weekly or monthly very precise quote unquote numbers of how many people have the disease. But I don't think then as now that was indicative of the number of people that actually have been affected, in that case by HIV, and in this case by COVID-19. This is a different epidemic in a lot of ways, but that's very similar. One reason the numbers that we see here are probably not indicative of the numbers of people that have the virus is that we have no antibody test, which means that if you are currently infected with the COVID-19 virus, you can be tested and they can find, since we've genetically sequenced the virus, pieces of the virus in you. But once someone has had the virus, there's no way to tell once the virus is out of them that they've had the virus unless they're actively infected. So with HIV, right, when we didn't even know it was a virus, looking back, they've gone back and looked for HIV and HIV antibodies in people's blood samples. So in theory, like in a year or 5 years or 10 years, we could go back and start getting a better denominator number that Chris was talking about of how many people have the virus. But since there's no antibody test, all of these mild cases where people then recover, right, would probably never know. And those obviously aren't included in those numbers up there. And at the beginning of the epidemic, right, we have all these 80% numbers. That comes from a study of, if you see in the news 45,000 people, it was actually a study of 70,000 people that were suspected to have the virus. But about 30,000 of those never got tested for the virus, even though they were suspected to be infected. And a lot of that was because there weren't enough tests. Right, and we're still seeing that problem. So if we look at the beginning of the virus in China, right, we have reports of purposeful covering up of people who had the virus by the government. We have people who were not tested because there weren't enough tests. We have people that weren't tested because they just had these mild symptoms and they thought, I had a cold, they didn't know what was going on. And so all of those numbers aren't represented when you see WHO or CDC numbers in these numbers like this. And also in the United States, right, it's not just a problem at the beginning of the virus. There are people who have traveled. News reports say 2 affected countries come back, had symptoms, their symptoms are mild, and when they ask to get tested, they say, your symptoms are mild, you're not on the top of the list, right? So those people may have COVID-19 and are not being tested. Other people who want to be tested, who may, right, have gotten the infection from the community, again, may not have enough, there may not be enough tests. I'm sure you've all seen the headlines about lack of tests, and as Chris said, that's getting better. But I just want you to know that when you see something like this from the New York Times, which is a beautiful, beautiful map, and it looks so precise, it looks like, right, I should go to Idaho. Because Idaho has 0 cases. Right? Something like this is really illustrating, and if you look very carefully, it will tell you, because this is the New York Times, of reported cases, But a lot of the headlines you see in different news outlets and things like that don't say reported cases. It makes it sound like we can count every case in the United States, when actually, if you look how those numbers are getting to us, probably the number of cases is much larger. And a lot of that is really because, right, people are not having these severe infections, so are not getting tested, they're just going about their daily lives. But those people could pass that to other people. So that's my bad news. Do you want to hear the good news? Yeah. Okay. Me too, right? After reading about this for so long. So I also want to talk about scholarly science communication and talk about two issues that I think relate to COVID-19, the time to publish and the access to information. So if you've been in one of my classes, get ready for a small review. When scientists want to share information with each other, for the past few decades, the way they do that is what? They publish a peer-reviewed article, right? They write an article in a peer-reviewed journal, and that journal is published, and other scientists read it, and they build on those results. These are written in a very conventional way that you can get the information quickly out of them. You don't have to read the whole article. But this process takes a lot of time. This is from the Journal of Food Research. This crazy chart. This is showing people that submit to the Journal of Research all the steps you're going to have to go through before your article actually gets to publishing. And then once your article is published in one of these journals, it's accessible only to either someone who can afford to buy the journal or someone who is affiliated with someplace like Muhlenberg, and that institution can afford to give its faculty, staff, and students and other affiliated people access to the journal. So there's a lot of conventions in scientific publishing. A lot of these have a lot of value, right? The method. Right? You've heard me talk about method if you've been in my classes. It's transparent. I will tell you in my scientific literature article how I did my experiment. So you can replicate the experiment, and that gives evidence over time, right, that this is working. That's a great value convention. This idea of peer review, this idea that other experts are going to review my work before it is allowed to be in the published record, and that's kind of a gateway so that things that aren't up to a certain standard don't get out. But in a public health crisis, all of this time that takes and all of this lack of access that people have is not great. I think that people would want information to go to people who can help in the situation as quickly as possible, available to anyone who can utilize it, and also available to anyone, like everyone in this room, who might be affected by the public health crisis and just want more information because it has a direct impact on their life. So we want access and speed, two things that the current way we communicate among scientists don't really give us. So this is not the first outbreak, right, where this has really been problematic. The first time I saw a lot of discussion around this was in the Zika outbreak of around 2015, 2016, where it felt that the speed of science publishing was not really matching the speed of science information needed. So when we hit this new crisis, the question is, what structures exist to share science information outside the bounds of traditional publishing? Because I think, like, right, this panel, we already had the structure for this panel. So when this crazy new public health issue came up, Chris and I said, oh, we already have a panel structure. Let's do a panel. Happened like that. Right? When you have structures pre-crisis, it seems a lot easier to use them rather than trying to create structures mid-crisis, which is probably why pandemic experts have been criticizing and begging the United States government for years to set up structures to address pandemics before we're in the middle of a pandemic now, and have to deal with it then, right? Have to create structures then. So advocates for years in the sciences, both librarians and scientists, have been advocating for more access to science information, for quicker turnaround. This has resulted in things like Plan S in Europe, where all grant-funded articles in about a year will have to be published in open access journals. It's resulted in open access journals, these journals where if you publish in them, your content is freely available to anyone who can get to the web. Things like PubMed Central, where if you have an NIH grant, so basically your research is partly paid for by the American taxpayer through the National Institute of Health grant, right? You have to put your content freely available online. NSF has similar rules. So all of these things, right, have been building for many years. And then in 1991, which was actually very early, the physicist really bypassed the biologist, and they made arXiv. an archive for preprints. And preprints are manuscripts, that have not yet been peer-reviewed or published. And so in physics, it is now the convention that when you write an article, sorry, that, I should not have practiced this 37 times, so now I'm losing my voice. So when you write an article, you put it in archive before it's been peer-reviewed, and everyone can see the content right after you wrote it. So why is this important? Well, this is important because in the interim before COVID-19 hit, biologists copied arXiv and did something similar. And they made medRxiv and bioRxiv, and they were kind of just sitting out there, not used very much. But interestingly, in this crisis, things like this and other open access resources have been flooded with COVID-19 articles. And so one of the reasons we have all of this information 3 months after this crisis started is all of these biologists are putting up their manuscripts on these preprint servers and not worrying about, hey, it might affect my job because I can't get published in the high impact journal I want to get published in because I already put my stuff freely online. Instead, they've said, it's really important for the public to have this information. I'm going to put it up here and worry about what journal I'm going to be in later. I think that's all my voice is going to take. Thank you all so much. I'm going to pass it on to Casey.
Hello, everyone. Okay. Is that there? Okay, awesome. Thank you so much for coming. My name is Casey Miller. I am an assistant professor of anthropology here at Muhlenberg in the Department of Sociology and Anthropology. And I do research in China and also in the field of medical anthropology, which is why I think I was asked to talk today with all of you. And I'll be offering some lessons or perspectives from the field of anthropology and medical anthropology in particular to think about COVID-19 and the epidemic so far. And I'll also be comparing and contrasting the response to the epidemic that we've seen in China and also so far in the United States. We'll see what similarities and differences we can perhaps see. So many of you might not be familiar with anthropology, and that's okay. We're used to that in anthropology. I'll just talk really quickly about what medical anthropology is. It's a branch of cultural anthropology, which is the comparative study of human cultures and societies, that focuses on the study of human health and medical systems from a cross-cultural perspective. And these are two of the big questions that medical anthropologists ask. So one of them is, why do certain groups of people around the world seem to be more likely to get sick with specific diseases? And also, how likely are they, once they get sick, to get access to effective health care and to get better? So why do certain people in certain places tend to get certain diseases? And maybe why do certain people in certain places tend to get access to health care or not? And then another related question is, how do people in different cultures around the world interpret or make sense of and react to sickness and disease? So I'll be talking about both of these questions in relation to COVID-19 in my talk with all of you today. So we've talked a little bit before, previous speakers have addressed how COVID-19, from what we know so far, seems to have originated or was first reported in Wuhan, a city, and Hubei, a province in China. But I really want to get right out in front and address kind of the elephant in the room, which is that novel diseases like COVID-19 are not and must not be associated with particular cultures. And to do so is not only factually inaccurate, it is racist and wrong. And that we've unfortunately seen a lot of discussions in the Western news media, including even in publications like the New York Times, where people have said things like, why does China have so many novel viruses like COVID-19? Oh, it must be because Chinese people eat bats, or because there's wet markets where people often from lower socioeconomic brackets buy fresh fruit and vegetables in their neighborhoods. And this is just really wrong. So I'm here to tell you as an anthropologist that outbreaks of novel diseases like COVID-19 can and do happen and appear everywhere around the world, in North America, in the Middle East, in parts of Asia, including, but not limited to China. That being said, however, there are some political things going on, or aspects of China's political structure that I think you could argue did affect the initial response to COVID-19 when it appeared in China in December and in January of this year. So one of these is China's hierarchical political bureaucratic structure, particularly at the local and provincial level, which I'll be talking a little bit about. So this political structure discourages lower level and local officials from reporting bad news to their superiors in the government bureaucracy, which can often lead to attempted cover-ups and delays in initial responses to diseases like SARS, which we saw in 2002, and again, which we saw in the initial response to COVID-19. And this is also related to a tendency within the Chinese political structure at the local and provincial level to have these lower level officials try to cover up these epidemics or health problems, and also to punish whistleblowers from coming forward. So here's just a little sort of a chart that I put together. The Chinese bureaucratic structure is very complicated, but this is just a simplification showing the dual tracks in the Chinese government. So every level of the Chinese government, from province to county down to township and then at the level of village, is sort of directed by a representative of the Chinese Communist Party, either a committee secretary, county, township secretary, or local party representative. And also there's an official in charge of that level of government. So at the level of the province, you have the provincial governor, who is reported to by the county governors, and then the township magistrates report to the county governors, and then village council members report to the township magistrates. So when an outbreak or a disease or a problem happens at the village or township level, these people often tend to try to sort of handle it and deal with it themselves, and not to report sort of bad news up to the superiors, who are then required to report up to their superiors, and so on and so forth. And this can sort of make or break a political career, which is why you tend to see sometimes government officials and politicians reacting to a disease outbreak in China based on personal or national political concerns or interests about their personal political careers or futures. There was also a famous case, you may have heard of Dr. Li Wenliang, who was a Chinese doctor who passed away in 2020 of the COVID-19 virus. He was one of the first medical professionals in China to try to start getting the word out to the public about the existence of this novel coronavirus. And he is a doctor in the city of Wuhan, an ophthalmologist. And his efforts led him to be dragged into the local police station, where he was interrogated and forced to sign sort of a confession or a letter of admonition for spreading false rumors, when he had sort of to promise to knock off this behavior and not do it again. And then later he actually, in the process of giving care in a hospital setting, contracted the disease and died. And in China, he's now regarded by many as kind of a hero, one of the first people to try to be a whistleblower to get out news of the epidemic. You also see in China state control over and censorship of the media, including online media, social media, as well as official and unofficial media outlets. And the result of this sort of state control over media sources, online censorship, and this history of cover-ups of diseases like SARS and COVID-19 causes the public to often distrust official news sources, which can lead to panic and the spread of rumors and false information, which can also hamper the initial response to a disease like COVID-19, all of which we saw in China. So unfortunately, one of the reactions that people around the world have had to COVID-19 is to stigmatize and discriminate against various groups of people who they associate with the disease. And we've seen this around the world, including inside mainland China, where people from southern China are often stereotyped negatively as eating anything and blamed for the spread of diseases, even inside China, like COVID-19. You also see stigmatization of people inside China who are from Hubei or Wuhan, the city of Wuhan, even if they haven't been there for months or years and have no connection to anyone who's infected with the virus. You also see similar things happening in Chinese territories like Hong Kong and in Taiwan, where people who are from mainland China, not just from Hubei province or from the city of Wuhan, are stigmatized or discriminated against. So for example, in Hong Kong, there's over 100 restaurants at one point that publicly were refusing service to people who are from mainland China. And they posted signs here you can see on the left and the bottom right here saying that residents of mainland China were not welcome or were not allowed to be served in their restaurants, which is actually illegal in Hong Kong. So you also, unfortunately, have seen instances of stigmatization and discrimination and even episodes of violence directed toward people of Chinese or perceived Chinese or Asian ethnicity around the world, including in Europe, where a Singaporean student was beaten severely in London recently, and also in the US, where people who are Asian or who people think are Asian or Chinese have been attacked just going about their daily lives, walking on the street or riding a bike or taking the subway or shopping. So this unfortunately has been one of the responses that we have seen. So I want to talk a little bit about the situation in China today because a lot has changed since December and January of this year. And today it looks as if COVID-19 may be contained in China. So for the third straight day today, we have seen no new confirmed instances of COVID-19 outside of the province of Hubei and the city of Wuhan, which seems to indicate that it's possible that China has managed to successfully contain the spread of this disease within its borders, which I think is an amazing accomplishment, particularly if you consider the fact that China is a relatively under-resourced country with a massive population, that this COVID-19 virus hit China right at the start of the Chinese or Lunar New Year holiday, which sees the largest annual migration of human beings in the world, where tens, if not hundreds of millions of people travel around China to be with their families to celebrate this holiday, which could have really driven this outbreak. So China has really managed to turn things around, despite sort of initially not handling the response very well. And I think you can attribute this to three things. So one is the so-called authoritarian advantage, where countries like China that are authoritarian are able to marshal vast amounts of resources very quickly to scale up a response to a disease, and are also able to impose draconian travel restrictions and quarantines, so basically locking down entire cities or even regions or provinces of the country. And this seems to have been quite effective, if very draconian, effective in controlling the spread of this disease in China. You also have a long history of mass movements and social mobilizations in the country of China. So people have for a long time been able to be mobilized and are willing to make sacrifices often for the public good, and also they see the response to COVID-19 as a matter of civic duty and also national pride. So a lot of people in China are quite proud of their response to the disease and also the response of the government to the disease. And in fact, Xi Jinping, the leader of China, declared a people's war, or a sort of a mass war against the disease in China. And one thing that I don't think has been reported as much in the Western media is the incredible response we've seen of volunteers and civil society groups, both within China and also in the Chinese diaspora around the world, to the threat of the disease. So here's just a picture in Wuhan of one of the many hospitals that was constructed in 10 days, which is sort of amazing if you can think of the speed of that construction. Also, you've seen tens of thousands of doctors and medical professionals from all over China volunteer to go to Wuhan and Hubei to work on the front lines to fight this disease in very dangerous conditions and very difficult working conditions. You've also seen millions of local community and neighborhood volunteers in China mobilized to take care of the families of these doctors who have been left behind all over China, as well as to deliver medicines and groceries and check in on elderly and disabled people in Hubei province and the city of Wuhan who are being really badly impacted by this disease. You've also seen taxi drivers in Hubei and Wuhan who volunteered to serve as ambulance drivers during the quarantine when public transportation was locked down and there weren't enough ambulances. So putting themselves, again, at risk on the front lines to help fight the disease. And you've seen volunteers of Chinese citizens abroad, all over the world, organized to solicit contributions of money and also medical supplies, and to gather these medical supplies and get them shipped to China to places in Wuhan and Hubei where people need masks and other badly needed medical supplies. So how has the US response so far been similar or different to that of China? I think it's interesting to consider. So despite seemingly very different cultural circumstances and also very different political structures and systems, I would posit that the initial response of the Trump administration has actually been very similar to that of China's authoritarian government and the way that they responded to the disease in a number of ways. So the US has been very slow to respond to the disease and to scale up testing. Despite having many weeks or months of a head start, notice that China did not have, and despite being a much richer country, part of this might be the massive tax breaks that have been given to wealthy and big corporations recently, which have also come along with cuts to public health and the CDC, and there weren't enough tests to go around, and there still aren't, despite claims to the contrary. Also, like the initial response in China, American government officials in the Trump administration are denying the extent of the problem, and also, spreading propaganda, misinformation, and outright lies in many instances, including from President Trump in the news media. So just some of the most recent hits, Trump has said COVID-19 is just like the flu, or actually much less dangerous than the flu, though there are only 15 infected people in the US, which will soon be 0. that the disease will miraculously disappear when the weather warms up, that the vaccine will be ready in a few months, that infected people should keep going to work if they have minimal symptoms. He's called COVID-19 a democratic hoax. He's said that the tests are beautiful and perfect, like the Ukraine phone call, and so on and so forth. The government also in the US has attempted to silence whistleblowers and doctors, similar to what we saw with Li Wenliang in China, who are trying to get the truth out about the danger of the epidemic to the American public and media. And also we've seen an unfortunate politicization of the disease in the US, where I would suggest that some politicians in the US seem to be more concerned about how the disease is affecting things like the stock market or their own re-election prospects, rather than trying to get a handle on the disease and not really caring necessarily about the people behind these numbers that we keep talking about. Because if each one of these numbers, these cases, is an actual human person who's affected by this disease. So I just want to conclude by saying that another thing that we're seeing around the world, both in places like China and in the US, is that COVID-19 is disproportionately affecting some of the most vulnerable populations among us in our communities. And that we really need to think about this. In particular, in China, we've seen that the poor people, the elderly and disabled residents have been severely negatively impacted, in many cases being left to care for themselves or without care or food or medicine. And there's some really tragic stories of this coming out from China. We're seeing similar things begin to happen now in the US as well. Particularly, there are fears about the homeless population in large cities on the West Coast or the East Coast, for example, who are at extremely high risk of infection with COVID-19 due to lack of sanitary conditions, lack of ability to wash their hands or have sanitizer, and also lack of access to medical care. Also, there are questions about people who are uninsured or underinsured. So the COVID-19 epidemic is really exposing some of the stress points or weaknesses in the American healthcare system. So there are now announcements that people who have medical insurance will have their tests covered for COVID-19, but we have yet to hear about people who are uninsured or underinsured. Will they be able to have tests, or will they have to pay for these tests themselves? If so, how expensive will they be? What about undocumented workers who might not feel safe going and getting tested? And what about the working poor who are not able to afford to take time off work if they get infected, or they might be infected or they have symptoms, to self-isolate because they have to put food on the table or they have to make a mortgage payment? So just to conclude, we all need to look out for and care for one another. And I just want to end with these posters from Muhlenberg College. Listen to experts and scientists. Don't be selfish. Don't be racist. I think we might get through this.
I know this is a long time to be sitting, so as I pull up my slides, my public health offering to you is if you need a 30-second stretch break, if you need to stand up and stretch, now is your chance. And I'll get going in about 30 seconds once I figure out where my slides are. Oh. I think this just turned off. I think I need tech help. I'm sorry? I'm sorry, but I need to focus on this. My apologies. This is shutting down. It just started to shut down.
It just started to shut down.
Sorry. There I am. Thanks for being there to support the tech. All right, I'll get going again if everyone would take a seat. So I am an assistant professor of public health And my training is in epidemiology as well as in public health ethics. So I thought I would talk a little bit about quarantine because that is a public health approach that sits kind of right at the intersection of epidemiology and ethics. So I wanted to get started by giving you a couple definitions of a couple very common public health approaches to addressing the spread of infectious disease. The first is isolation. This refers to separating sick people, people we know confirmed have the disease, from people who are healthy. So for example, if you are on a cruise ship and you get tested and it's confirmed that you have COVID-19, if you are then moved to a hospital and put into isolation, that's when we would use the term isolation. Quarantine, on the other hand, is what public health refers to when we separate or restrict the movement of people who are healthy but may have been exposed to a contagious disease. So we restrict our movement and wait to see whether or not the disease develops. And finally, another term which we've started to see a little bit more in the news in the last few days, so you may have come across this, is social distancing. This is the idea of avoiding mass gatherings and maintaining distance, ideally about 6 feet or so from others when possible. We've also started to see this in the United States. Examples include closing large-scale conferences or canceling city parades or other mass gatherings of that nature. Why do we do this? This is why we do this. From a public health perspective, the major concern is our healthcare system capacity, and we want to change the trajectory of a potential epidemic to protect our healthcare system capacity. What do I mean by capacity? I mean both the staff of our hospitals, and that obviously includes physicians, nurses, all our health professionals who are trained to look after us. There are a limited number of those people. We cannot exponentially increase the numbers of doctors and nurses. We also have limited numbers of ICU beds. We have limited numbers of ventilators. We have limited numbers, as many of you have begun to notice, of masks, of goggles, of other physical resources. So our big concern is that line of capacity cannot be magically increased overnight. So instead, the purpose of protective measures, and protective measures here is including isolation, quarantine, social distancing, some mix of these, is to address where the peak of the epidemic is. We do not want the peak to go above the healthcare system capacity. If you take protective measures, on the other hand, the hope is you have a trajectory that looks much more like this blue line, where you keep the peak of the epidemic below the healthcare system capacity and you delay and spread it out over time. That is the goal. And we also have really good evidence of this from history. I'm going to give you a very classic example. This is from the 1918 flu epidemic, which was one of our worst epidemics of flu in American history. And this is a classic case study of Philadelphia versus St. Louis, and I regret to tell you that Philadelphia does not come out looking good in this particular historical example. So what happened, and I apologize that there's an awful lot of writing on this slide, but the main thing I want to emphasize here is that Philadelphia waited several weeks after seeing its first case before implementing any social distancing measures. So the parades went on as normal, all the massive gatherings went on for 3 weeks. And that gave the flu 3 weeks of time to spread and to start growing exponentially. And you can see what that did to the peak of deaths per 100,000 people in Philadelphia. Now contrast this with St. Louis, which got its first case on October 5th, and within 2 days began enacting social distancing measures, canceling mass gatherings and choices of that nature. You can see how incredibly different the epidemic looked in St. Louis. The peak didn't get nearly as high as it did in Philadelphia. So this is the reason you are hearing conversations right now of tough decisions being made about do we need to change our behavior, at least temporarily, to try to address what the trend of this epidemic looks like. Another thing I want to note, which has been mentioned by other speakers, is that we also want to think about whether targeted social distancing is something that might give us the best benefit. And the reason for that is we have data suggesting that the severity of COVID-19 indeed does increase sharply with age, and there's also greater risk for people with underlying health conditions, such as respiratory issues. So the idea, and this is from The Lancet, published just a couple days ago, is that we might want to be considering social distancing measures that prioritize those vulnerable groups as potentially the most effective way to prioritize the most at-risk groups. So that's what social distancing looks like. But I also want to distinguish that from quarantine, because quarantine is a very different approach. And quarantine does indeed tend to be more controversial than isolation or social distancing, because you are restricting the movement of healthy people. And in fact, legal scholars have described quarantine as the most extreme use of government power in the United States over people who have committed no crime. Public health is a field that has something that is often described as emergency powers or even police powers. We can use these powers to do things like shut down restaurants. We can also use these powers in times of crisis to limit people's ability to move around. That is a really important thing to think about from an ethical concern. That raises significant ethical issues I think we have to be thinking about. And the last point I want to make in terms of the legal aspect is that in the United States, the nature of our political system, as contrasted with China, which Professor Miller discussed, is that we don't have necessarily one centralized authority that's going to be making this decision. It is state and local public health departments that largely have the authority in the United States to implement and enforce quarantine or social distancing measures, which is why we're already starting to see, for example, in Seattle and Washington, perhaps more aggressive moves being made and less so in other states. It is very plausible that there is going to be a patchwork of responses that may vary according to state and locality for that reason. So why quarantine? Why take such a drastic approach? We have evidence that targeted small-scale quarantine efforts can be very effective in reducing transmission. I've picked one specific example. There's many others. This is of some cases of measles that happened in a particular school in Geneva, Switzerland. And these numbers are probably quite hard to read, so let me just read them for you. All I want to highlight is that from the study, the 50 people who were quarantined had a 12% transmission rate of measles. The 173 people who were not quarantined had a 47% rate of transmission of measles. That is a very big difference. Why did this quarantine work so well? One reason is that it was very targeted. It was just in this specific school that had cases of measles. And another reason was that compliance was excellent. People went along with the quarantine for several reasons. One is that there was really strong support from school health services, really good communication. The community was on board. They said, this is what we need to do. So we have good evidence that small-scale targeted quarantine efforts with support from the community, with good compliance, can make a difference. Nonetheless, there's some really important ethical prerequisites we need to think about before imposing any such approach. The first is a public health principle known as proportionality, or sometimes referred to as least restrictive means. This ethical principle states that you should take the least restrictive approach possible to attain your public health objective. What that means is that if there is any option less restrictive than quarantine that will work to reduce transmission according to your goal, that is the approach you should take. The second ethical principle I want to emphasize is reciprocity. What that means is that if society is asking individuals to curtail their freedom, to curtail their liberty in any way for the good of other people, we in turn as a society have an obligation to them to help them out. And that means if you are under quarantine, we need to help you out with getting food. We need to help you out with getting your medication. We need to help you out with anything else that you need because we are asking you to impose some limitation on yourself to help protect the community as a whole. Another final ethical principle I want to highlight is transparency. If you are going to implement a quarantine, you absolutely have to clearly communicate with people. What is the justification for this? What is the plan for this? What is the means that we're going to use to keep communicating with you as events unfold? The public needs to know all of that information for an ethical quarantine to be imposed. However, there's a couple other ethical considerations I also want to point out, which is we have very little empirical evidence on large-scale quarantine. So we have that good evidence of schools, specific locations with specific concerns having a good effect. We don't have such good evidence on large-scale quarantines, in part because we haven't had a lot of large-scale quarantines. What is happening right now in China, in Italy, and several other places is quite frankly unprecedented. We do not have lots of epidemiological data on what happens when you have a lockdown of millions of people because we really have not done that before. So I cannot tell you how effective that is, but I can certainly say we do have evidence from the SARS epidemic that there was a little bit too much quarantine. In other words, that sometimes the quarantine measures went beyond what was necessary. So I think it's going to be very, very important to be thinking of what evidence do we have, what is the scale of that evidence, when is quarantine potentially justified, and to what extent is it justified. Another point I want to emphasize is that when you're planning quarantine, you need to think about the totality of the effects on individuals and on society, not just the projected effects on infection rates. So going all the way back to this slide, which I love to pieces and is really important and is something we have to think about, it is not the whole story. So even if you have those great, wonderful protective measures that bring the epidemic peak down of the particular disease you're concerned about, you still need to be thinking about, what about people with cancer? Were they able to still get their chemotherapy? What about kids who depend on school lunches? What happened if that school was closed? Were they still able to eat? The effect of quarantine is not something we should be thinking about just in terms of COVID-19 infection rates, as important as they are. We need to be thinking about the effect of COVID-19 on society as a whole and use that information to help guide our decision-making about when, whether it's justified, and if it is justified, how do we make accommodations for the broader health needs and the broader needs of the community. I also want to note that there are real harms to social separation that are really important to think about. When you are engaged in social separation, be it social distancing, quarantine, or isolation, you have risks of disrupting social and economic life profoundly. You have risks of loneliness, detachment, anxiety. You are infringing on individual rights and potentially with really important, faith or family or other cultural values that need to be considered. For example, are you limiting people's ability to attend a funeral or a religious gathering or other highly valued event? And you need to be thinking about that. And quarantines and social distancing and isolation can sometimes make it more difficult to protect vulnerable people. If you're disrupting transportation, for example, you might be disrupting the provision of food, water, clothing, or medical care. In the sake of time, I just want to quickly say, if people want to talk more about specific examples, I have a couple examples from China, from Italy, and from South Korea. But what I want to wrap up by saying is that when we're thinking about quarantine, or even just thinking about the prospect of quarantine, that alone can cause some of those social harms I was describing of suspicion, fear, stress, and social disconnection. So I want to echo what Professor Miller said and say that now is the time for the opposite response, to be looking out for other people. And in particular, I want to quote Atlantic writer James Hamblin, who put it this way: societies break down when people begin to fear one another as simply walking distributors of infectious agents. None of us are that. We are all people, and so we need to be seeing people as allies in this very unique moment of uncertainty when, as Dr. Cronin pointed out, we still don't have perfect numbers on numerators, we still don't have perfect denominators. We're going to have to make some tough social decisions based on uncertain scientific information. And as we have those big, difficult conversations about those decisions, we need to be seeing each other as allies in making those decisions together. Thank you very much.
Thank you very much for having me here. My name is Lu Fei Teng. I'm from ABF department, teaching economics and finance courses here at Muhlenberg. My topic today will focus on the economic impact of COVID-19. I've been constantly changing my slides over last week. Things are changing all the time. New economic policies are coming out. I made my last change 2 hours ago. Hopefully, it's still updated, at least until 7:30. So I'm gonna do first of all, I wanna do a quick comparison between SARS and this coronavirus. Yesterday, I realized that my students, they're too young to have memories of SARS. but I'm still gonna do the comparison here. So all economies, they have three major sectors. They have services sectors, manufacturing sector, and extraction of raw materials. Well, during the period of epidemic, which sector is affected the most? Service sector, yes. Like people would stay at home more, avoid gathering, avoid having fun out there. So restaurants, movie theaters, transportations, retail activities, they will be hurt badly. And they are all in services sector. Service sector, they are the largest job providers for the whole economy. About 80% of working population is hired by services sector. As you can see here, now China, the most important sector in China is services sector. The same here in the States. Well, over the last 2 decades, China has become the second largest economy of the whole world. Last year, 16% of the GDP, global GDP was contributed by China, and the US has the largest economy. Together, these two countries, they account for 40% of global GDP, which means that if these two economies are out of control, ripple effects will be too large for other countries to take. And it seems that China now is under control. It's US turn now. All right. So this is the real GDP growth rate over the last 2 decades. The green line is China. Advanced economies is yellow line here, and we have the gray line for the world average. During the period of SARS, at that time, that was the first year China became the member of WTO, World Trade Organization. Since then, China has become the largest trading partner to many, many countries around the world, and it was in the middle of upward trend. So as you can see here, that the impact of SARS on our economy is very little. Actually, we see increase in growth. Let's see what's going on right now. So last year, China had the lowest growth rate over the last 4 decades. Before this outbreak, there were 3 major concerns embedded in Chinese economy already. We have aging population problem, we have heavily leveraged infrastructure construction, and we have competition with the US. We had the US-China trade war. Finally, the first stage of the trade agreement was settled last year. We were so happy, we were so ready for this new year. We were positive about economic outlook. It was projected about 6% growth rate, and then this occurred. So we are certain right now that we're gonna have a global slowdown for sure. And the impact of this coronavirus on our economy will be more dangerous and broader than SARS. But I'm not going to say, but it's still too early to assess that are we going to have a recession or not. I don't think China will enter into a recession. The new projected number is there will be a reduction in growth rate from 6% to around about 4 to 5%. Well, for the States, I think it's too early to assess the economic damage because we are at the start of the whole process. I'm afraid that for Eurozone countries like Italy, they are on the brink of a recession. Especially for Italy, this whole country is under lockdown, and its economy was fragile before this outbreak, and it relies on tourism and fashion. So, but again, like I don't know if we're gonna have a recession or not. Let's see what happened yesterday. We had stock market crash, we had record low 10-year treasury yield, and we have oil price plunge. So for now, it's still too early to have a solid estimation about fundamental damage. But these 3 events tell us that we are having a serious market panic. What? Sorry. We are having a serious market panic. People have fears. And another impact here, there is a global supply chain disruption. In China, factories are shut down for over 6 months. Now, except for the center of this outbreak, Hubei province, all the other provinces, they just go back to work. They are resuming their production. I know that Apple will postpone its launch of new iPhones this year. But I will see that this supply shock is temporary. Because not like a war or natural disaster, factories are destroyed or damaged, they are still there. The production is just postponed. After this break, people go back to work and the production could be made up. But the problem is, are we going to have the same demand? New iPhones will come out sooner or later, but are we going to buy it or not? That's the question. So I would say that we have supply shock, we have demand shock, but it's more of a concern. Demand shock is more of a concern than supply shock. All those disruptions, economic disruptions, they are temporary. I'm afraid that there will be a long-term impact on ideology. We have seen the rising of protectionism, and I'm afraid that after this, we're going to have a further push toward deglobalization. So let's see what is the impact of market panic on our economy. If we feel nervous, if we have negative expectations about our future economic conditions, we'll be very cautious about our income. We're going to reduce our consumption, and for firms, they would hesitate to produce. Less production lead to less employment, and people have less income, more fears. So we're going to stay in this vicious circle. So the purpose of economic policies is to break this circle. Let's see what the economic policies we have so far and how it works. There are two types of economic policies. We have fiscal policy, we have monetary policy. And fiscal policy is conducted by the federal government. Monetary policy is conducted by the central bank, the Federal Reserve. And there are three fiscal policy tools. We have government purchase. For now, we have $8.3 billion emergency spending package. They are used on medical treatment and infection protection. And in China, the spending on that is $110 billion. While for tax, there is a debate over that. The president proposed a payroll tax cut, and they are still debating on this. We don't know they are having meetings today. I'm not sure about the result. There are three major concerns regarding this policy. First of all, payroll tax cut will only apply to people who have jobs already. And second, our current budget deficit is around $1 trillion now, which is 4.6% of our total GDP. I know budget deficit is not priority at this time, but we eventually will have to face that, right? And the third policy tool is transfer payments. And also the third concern regarding payout tax cut is the immediate effects of this policy are very limited. Like we now have immediate need for this issue. Okay, for transfer payments, that is the free money we can get from government, and it seems that we're going to have compensations on sick leave workers and hourly workers. The question is, do we have an immediate need of a broader fiscal policy response? My answer to this one was no. I put no yesterday, and then I changed my mind. It seems that there is a rising liquidity risk posed to small businesses. Normally, for small businesses, they hold 3 months cash flows on hand for their daily operations like wages, utilities, overheads. And if people choose to stay at home, reduce their consumption, it's going to be very hard for those small and micro businesses. And they need liquidity. In other words, they need loans available for them, cheap loans available for them. And monetary policy. Last week, we have emergency cut on our short-term interest rate. Now our short-term interest rate is from 1% to 1.25%. And I believe there will be another cut later this month. So it can be anticipated that we're going to have zero interest rate, which means negative real interest rate. Are we going to have liquidity injection? My answer to this one is I don't think so. We did this last time. What is liquidity injection? Printing money. We did it last time to deal with financial crisis 12 years ago. At that time, we had two processes. One is we want to push down long-term interest rate. Well, if you look at our long-term interest rate right now, it's below 1%. It's nothing. Well, the second purpose of liquidity injection is to solve the liquidity risk in financial system. But at this point, there is no liquidity risk in our banking system. It's not a financial crisis yet, it's more like a public health crisis. But this is just what we have right now. We don't know how far this is gonna go, how serious it's gonna be, so we'll see. But up to this point, I don't think there is any necessity for liquidity injection, but we do have a large scale of liquidity injection in China, especially for those small businesses and the small banks. So if those policies are efficient and people's expectations can be changed, market confidence is restored, then we will go back to this virtuous circle here. We feel confident about our future. We increase our consumption. We have more expansion, more employment, and we are richer and we are happy. So we had recessions before. Economy recovered. And maybe we're going to have a slowdown. We're going to have a recession. But I assure you, this will not last forever. We'll come back for sure. But virus has been with us for millions of years and will be there forever. And it's a long-term war. So in the face of this, we are one. Thank you.
Thank you so much to our panelists. Let's give them a big hand. Does anyone have, I know we've gone over time, does anyone have questions for any of our panelists? Yeah, go ahead and come on up. And if you have a question, just step up to the mic and ask the question. Anyone?
Do you know of any preparation of by the hospitals? For instance, maybe one of the large hospitals would specialize in isolation wards, and the other would take all the other cases?
I know that Lehigh Valley Hospital is prepared. They're ready. They have enough of everything. That's what I was told over the weekend to accommodate sick patients. I don't know about St. Luke's. It could get overwhelming very fast, though. And I mean, a couple of years ago, we saw what happened with the flu, where Lehigh Valley Hospital had tents out in the parking lot. So, most of our hospitals in the Lehigh Valley work at maximum capacity. There's very few beds open for people on, every day. And so if we begin to overwhelm our hospital system in the Lehigh Valley with COVID-19 patients, you have to wonder where those other patients are going to go. So, I mean, it's going to be tight. It's going to be a challenge.
You had mentioned that COVID-19 is in the same family of viruses as the common cold. Do you know of any potential for these two viruses under the conditions of co-incubation to possibly undergo genetic shift and become even more infective?
Well, I mean, it's one of the families of cold viruses. I mean, there are other families that cause the common cold too. But I mean, there's always a chance that there will be some kind of genetic recombination of a virus that makes it either less lethal or more lethal. So the answer is yes, there's a possibility of that happening.
Does a virus like COVID-19 have a lifespan? Does it die out at some point over time?
So that's a good question, and I'm going to answer it two ways. The first thing is, people are wondering how long does it last out in the environment, like on a surface. Right now, it's anywhere from 2 to 9 days, probably a little closer to 2 than 9, but we don't know for sure yet, so that's the first question. And the second question I think what you're asking, Tony, is when is this going to go away?
Right. I mean, don't viruses just at some point die and go away or not?
It depends. So if they don't have a host, then they can't keep replicating and they can't live. So there's a couple of ways that can happen. One is everybody dies from it and there's no host, or the other way, the preferable way is everybody becomes immune to it, or there's a certain amount of the population that becomes immune to it so it can't infiltrate. And that's the whole idea behind vaccines, right? We make over 95% of the population immune to the disease, and so the virus really has nowhere to go. So what I think we're probably seeing in China is a little bit of both of those things, where a lot of people have died, and the people who are still left have some kind of immunity. They've had the disease and now they have long-term immunity. And so now the virus, it's sort of like they were vaccinated, only they had the disease themselves. And so now the virus has really nowhere else to go, so you're gonna see it start to decline. We're not anywhere near that yet in the United States.
So as citizens, we may encounter people who are not as knowledgeable or receptive to this information. Just from the various standpoints, any tips on how we can effectively communicate this information and then stress wanting to protect the vulnerable populations?
Sure, I'll speak to that, and I apologize to those of you who are my students who may have heard me say this before, but my message has been, don't panic. But not panicking is also not the same as doing nothing. So it's, from my point of view, really important to get the message out that this is not a cause for panic. You don't need to remove all the toilet paper from the shelves of your local Target. That is not a practical or necessary strategy right now. But the practical, necessary things to do obviously include all the messages we already heard about washing your hands, staying home if you're sick. But I'm also adding to that, be prepared for social distancing measures. Obviously, if you have a cruise planned to Italy right now, I would reconsider. Obviously, right now, more local, smaller scale gatherings are still taking place. Then there are decisions that are going to be more on the border, in between. But I want us all to be thinking about those decisions, because I still do think, because we don't have a vaccine, that in addition to hand washing, we need to seriously consider at least some level of social distancing to buy ourselves the time for some of the things Dr. Cronin described in terms of developing a vaccine, implementing other measures, to have that in place, because we obviously want the long-term trajectory of this to be the development of immunity, ideally through a vaccine or otherwise less harmful way to develop immunity. And I think we need to be making those choices as a society to make sure we're getting to that point in a way that protects the most vulnerable among us.
I would also say, just for everyone in this room, to try to get your information from places where you know that the goal of the information is to protect the public health of the citizens of the world or the United States, and not places that are trying to politicize the information or are trying to use the information for some other goal. And just talk to your family about what evidence-based information is, and that with all evidence-based information, there is always the possibility that we may be wrong, but that there is all of this background trying to do things again and again and again to make sure that we are right. But I know it's so hard when you're talking to people and they just are saying things that sound so crazy to you, and you say, I have the evidence, and it doesn't seem to matter. But I feel like there are a lot of really, if you go to the CDC or the National Library of Medicine, they have information for EMTs, for elderly populations, for people in nursing homes, for people that are going on a cruise. They say don't. So there are information for different populations that might help you find something that's relevant to the community that you're talking to.
I actually might quickly add to that, just as a mental health piece of advice. It is obviously very anxiety-inducing to open up your computer or your phone and to see a nonstop stream of coronavirus updates, and particularly for the reasons that we've heard described about many of these numbers are not necessarily reliable, they're constantly changing. So I would also recommend, and you can recommend this to friends and concerned people as well who are having a lot of anxiety, maybe just say, this is going to be my 5 or 10 minutes today to get updated on the news. I do not need a 24/7 injection of social media on this topic. So I think balancing staying informed and monitoring the situation without sort of overloading on constantly changing information, especially if it's from unreliable sources, might be another good thing to be sure that we're recommending, not just to make sure we're getting reliable information, but also just to protect our mental health as we're moving through this.
Hi there.
Tell me how to symptomatically distinguish between this coronavirus and other viruses or the flu, and what should we be looking for so we could alert our families about how to distinguish when we should seek treatment or whatever.
I like your shirt. I'm from New Hampshire. Live free or die, baby. So sometimes it's going to be hard. If you have very mild symptoms, you might not know which one of those things you have, and the only way to tell is if you went and had a confirmatory test. However, in some cases, it will progress, and it will progress to a point where you will know that you don't have a cold anymore, that something is more severe, and that's usually because you have a fever, dry cough, and that shortness of breath that comes. And certainly, if you are at that point, you should probably call your doctor and speak to your doctor and maybe be seen by your doctor for evaluation. So you got to listen to your body. If you have symptoms more severe than you normally do when you have a cold, then I would call your doctor. And that's another thing. Call your doctor. Don't just walk in. And don't just walk into the emergency room. It's always best to call your doctor, tell him or her what your symptoms are, and then your doctor can facilitate your arrival to the hospital so that you don't infect the whole ER.
Okay, so Robin, do you have a question? We're going to take one more question because we're running over time, but I want to encourage you, if you have individual questions, to come up and talk to us after.
Hi. First off, thanks so much for the wonderful presentation. I really appreciate it. I was thinking about what Professor Miller said about the situation in China with one of the first responders who was silenced in the moment. I know it's a very different situation in America, but I think we all know there's very indirect ways that certain people have been able to manipulate the media and what type of information is being spread. So I know a lot of people are getting what they believe to be the most accurate information from the CDC and WHO. So I was just curious, because I'm unfamiliar with how they operate, does the CDC or WHO have any influence from the government or other figures who may be able to benefit from certain things being spread about it? Like you were saying, some people and businesses are trying to capitalize off of it. Would you guys know by chance?
So it's really interesting reading media reports about the current administration's messaging versus the CDC, because the CDC is a member of HHS, Health and Human Services, which is a branch of the executive branch. And I'm sure we can all speak to this, but Tony Fauci is the head of NIAID, which includes infectious diseases for the NIH. This is a lot of acronyms for the National Institute of Health. And he was around in NIAID during the AIDS epidemic, which was in the 80s. So I assume that he's been there 30 or 40 years. So I assume he's at the end of his career. And he, when he is interviewed now, says things like, I'm going to say what I think. I'm going to tell you, medical information, which leads me to believe that it feels like the administration is pushing messaging toward some of the federal medical branches, but I really think that they have been working hard to put accurate medical and scientific information out there, perhaps despite this. So that's why I would stick with that. The WHO, interestingly, has been actively fighting rumors, and now they have a branch of the WHO that takes rumors and answers them both in pictures and word form. So I haven't seen any rumblings about the WHO being influenced, but I know that there was talk at the beginning of the epidemic that WHO was working hard not to irritate Chinese leadership and praising China because they were being are being a lot more open than they were in the SARS epidemic. China got a lot of flack for how they reacted in the SARS epidemic. So I think the CDC and the National Library of Medicine is still filled with the career government scientists who are just working really hard to get adequate public health information out there.
Let's give one more hand to our panelists. Thank you, everyone.